Hi everyone, welcome to our tutorial on ESBL and AmpC. First, a bit of history. As we all know that first beta-lactam antibiotic penicillin was discovered in 1928 by Alexander Fleming. This penicillin, however, was not introduced into the clinical practice until the Second World War around 1940s. Around the same time, some researchers discovered an enzyme called penicillinase being produced by some bacteria which is able to break down penicillin and make it ineffective. So this battle between penicillin and penicillinase started at the very beginning, at the dawn of the discovery of beta-lactam antibiotics, and this battle is still ongoing. Subsequent to this, we discovered many other antibiotics, beta-lactam antibiotics like amoxicillin in 1972, first generation cephalosporin in 1967. This is specifically, it was cefalexin, coamoxiclav is 1972, second generation cephalosporin like cefuroxime in 1971, third generation cephalosporin like cefotaxime in 1976, fourth generation cephalosporin like cefepime in 1982. So these years might be slightly different if you go and search for specific antibiotic. I have taken the commonest example that we use clinical practice and put the discovery year in there. But what happened because of this discovery is we put antibiotic pressure on the bacteria. And bacteria, as they have to survive, they started producing beta lactamase, which has broader and broader spectrum. So after penicillinase came broad beta lactamase, which were able to break down antibiotic like amoxicillin or first generation cephalosporin or second generation cephalosporin. However, after that, when we introduced third generation cephalosporin, came the ESBL and AmpC. So that was like 1980s when third generation cephalosporin was being introduced. Bacteria started producing ESBL and AmpC, and then came the carbapenems, which we will discuss in a different presentation. As you know, that we differentiate beta-lactam antibiotics into four classes based on their spectrum and what was the structure like. So this classification is called Ambler classification. There is another classification called Bush and Jacobi classification, which is also important for the exam, and there has been question asked on that, but we will not go into that one in there in this presentation. In the Ambler classification, there are four types of beta lactamase. Ambler class A, which has a serine inside their molecule, in the core of their molecule. Ambler class B, which is metallo-beta-lactamase, and it has a zinc in the middle of their molecule. Ambler class C is again a serine serine beta-lactamase, and Ambler class D is a serine beta-lactamase as well. Now, class A and class D, these two classes has all sorts of beta lactamase in them. So penicillinase was like narrow spectrum, and then came the broad beta lactamase like TEM1, TEM2, SHV1, which were able to break down, as I said, amoxicillin, first generation cephalosporin, and second generation cephalosporin. But from them evolved the ESBLs, which were like able to break down third generation cephalosporin and fourth generation cephalosporins as well. So some of this ESBL evolved from broad beta lactamase like TEM3, SHV2 came from TEM previous TEMs which existed before, but there were some which were new like CTXM, which is absolutely new. ESBL was discovered. Similarly, OXA10 was a narrow spectrum beta lactamase, but or you can say broad beta lactamase, and from then on came ESBL of OXA group in Ambler class D, which are like OXA11, OXA14, OXA16, OXA17, etc., etc. So class B do not have any ESBLs; it only have carbapenems. And Ambler class C do not have any ESBL or carbapenems; it has only AmpC. So these are the AmpCs. So these are ESBLs, these are ESBLs, these are AmpC. These are carbapenemes, these are carbapenemes, these are carbapenemes. So ESBL was discovered in 1983 and AmpC was discovered in 1989. And these two enzymes are able to break down these antibiotics. So amoxicillin, penicillin, of course, is they are able to break down penicillin, but also amoxicillin, coamoxiclav, first generation cephalosporin, second generation cephalosporin, third generation, and fourth generation cephalosporin. But what they can break down is not uniform. There is some certain differences, and which we use to identify them. So these are the differences. ESBL is able to break down all sorts of cephalosporin except cefamycin group of antibiotic, which is a type of second generation cephalosporin. Example is cefoxitin. So it is able to break down all sorts of cephalosporin except cefoxitin, and it is it cannot break down coamoxiclav and piptase as well. So clavulanic acid is traditionally an inhibitor of ESBL. This is very important to remember. So is cefoxitin. Please remember this too. AmpC, on the other hand, can break down everything from amoxicillin to third generation cephalosporin, but it cannot break down fourth generation cephalosporin, which is cefepime. With this, we have already discussed that clavulanic acid is an inhibitor of ESBL. There is also inhibitors of AmpC, which are cloxacillin and boronic acid. Again, it's a very important piece of information, and you should remember it. There are a few things about AmpC. So there are strong inducers, which are like amoxicillin, coamoxiclav, and cefoxitin, imipenem. We will explain this again later on. But this is something that we also use to identify AmpC. So let's go to ESBL. So ESBLs are, again, as I told before, is able to break down amoxicillin, but not coamoxiclav and not piptase, but able to break down all sorts of cephalosporin except cefoxitin. Its inhibitor is clavulanic acid, and also you can say tazobactam. There are various type of ESBL from TEM family, SHV family, but the commonest one is CTXM. How do we identify ESBL? So to identify ESBL, you have to first screen for it. And the screening mechanism uses two sorts of uh, methods. This is taken from UCAST. So either you screen with cepodoxim, which is a very sensitive antibiotic for ESBL screening, but it has low specificity. The meaning is that if you use cepodoxim to screen, then you might have few false positives. So why use that? It is because it is sensitive, so it's unlikely that you will miss ESBL, and there might be situation where you do not have opportunity to put many antibiotic discs on a plate because of cost constraints or something. So one example is urine, when we traditionally put like 6 antibiotic discs on a culture plate, on an antibiotic sensitivity plate, and that's it. So in those cases, if you use cefotaxime and ceftazidime, you are using up 2 slots for antibiotic. Instead, you can just use cefotaxime if you want to screen for ESBL, and that will be all. So that's why you use cefotaxime here. On the other hand, in other specimen like blood cultures, if you want to screen for ESBLs, you might want to use cefotaxime, ceftriaxone, and ceftazidime. You might ask that why cefotaxime, ceftriaxone, and ceftazidime? Can we not do it only one third generation antibiotic? You can, but there is a chance that you might find some type of ESBL. For example, CTXM preferentially hydrolyze cefotaxime, so they might not hydrolyze ceftazidime that well. So if you use cefotaxime as screening, then you are going to identify that, but you just use ceftazidime, you might miss it. Similarly, SHV might preferentially hydrolyze ceftazidime, but may not be that good for cefotaxime, so you might miss SHV if you use cefotaxime but not ceftazidime. So that's why 2 antibiotics are better. There are zone sizes and MIC in UCAST guideline. You can check them from there. Whether you need to remember or not, I am not sure. I don't think personally that it is needed to you need to remember it, but sometimes questions may come like that, especially in part 2. So you must at least cast an eye on them. What happens if you find that cepodoxime or your screening with cefotaxime ceftazidime is positive. If you find screening is positive, then you go for confirmatory test using clavulanic acid. This is how we do it. So once we find that the screening is positive, then we divide we do our confirmatory test based on what bacteria you are testing. So you need to identify the bacteria. If you find those bacteria are one of these, which I mentioned here, like Enterobacter, Citrobacter fruindia, Morganella morganii, Providentia stewarti, Serratia, or Hafnia, then you have to use fourth generation cephalosporin with clavulanic acid. This is because these bacteria are AmpC producers, and if you use third generation cephalosporin to test it, it will break down the third generation cephalosporin and your test will be invalid. So if you are testing a AmpC producing bacteria, then you should be using cefepime with clavulanic acid. On the other hand, if you are using or if you're testing a bacteria which is normally not AmpC producer or not prolific AmpC producer, shall I say, like an E. coli or Klebsiella pneumoniae. In those cases, you can use one of the third generation cephalosporin with clavulanic acid to see whether there is any synergy. So it's important to remember. So, for example, assume that this is the lawn of the test bacteria that you are going to test, like an E. coli maybe, and then you put a cefotaxime disc and you put a cefotaxime clavulanic acid disc. Now, if it's an ESBL producer, it will break down cefotaxime and you will have a very small zone or no zone around cefotaxime. But because clavulanic acid is able to inhibit it, you will get a big zone around cefotaxime clavulanic acid. If you are testing for this bacteria instead of cefotaxime, you should be using cefepime here. Now, a few more things to remember. By any chance, if you have already, while you are testing, like you are doing screening or initial testing, if you have tested cefoxitin and you found that it is resistant, then do not try to test with third generation cephalosporin because a AmpC might be hiding there. And in this case, you go for testing with cefepime. If you find already that cefoxitin is resistant, go for cefepime clavulanic acid. There might be situation when you are testing for this group of bacteria with ceftazidime and clavulanic acid, you found an indeterminate result. What would you do? In that, if you find an indeterminate result, you use cefepime clavulanic acid to test. So go for fourth generation cephalosporin. What happens if you find an indeterminate result here in this group? In that case, there is no way but genetic testing which will give you answer. There are some images that you might come across in the exam and might ask you to interpret or take it from here. It might be an auspice station. So here, say cefotaxime has been put in and then cefotaxime, very narrow zone around cefotaxime. But the zone around cefotaxime clavulanic acid is large. So clavulanic acid is doing something here. That means it's likely to be ESBL. Here, ceftazidime, small zone, and big zone around ceftazidime clavulanic acid. So there is clavulanic acid synergy here. Clavulanic acid synergy here. So that means it is likely to be an ESBL. Here, this is another one. This is like keyhole test. So here see cefotaxime. There is no zone around cefotaxime, but this is amoxicillin clavulanic acid. So clavulanic acid is diffusing into the medium, and here clavulanic acid and cefotaxime it is producing synergy, and that's why you are seeing a zone here. Normally you wouldn't have seen zone because cefotaxime would have been broken down. Here ceftazidime zone here, but it should have finished like this, but you see an extra zone. That is because clavulanic acid is inhibiting the ESBL, and that's why you are seeing this extra zone. Now this one, see, this is preferentially hydrolyzing cefotaxime. No zone around cefotaxime, but there is zone around ceftazidime. So this one is an ESBL, and this one likely to be CTX-M type of ESBL. These are the images that might be given in the exam as well. It's a possibility. So this is the E test for ESBL. So you see, this is cefotaxime. This is cefotaxime clavulanic acid, and the cefotaxime MIC is 1.5, but see the cefotaxime clavulanic acid MIC is 0.47. So definitely it has better, like lower MIC, and it is likely to be an ESBL. Then you will find that this one is kind of uh, piptas. Sorry, this is ceftazidime, and this is ceftazidime clavulanic acid. And here again, see the zone size. So MIC would have been like finished here, perhaps 2. Here, obviously, the MIC is much lower than that, 0.64, but at the same time, there is a phantom zone here. So here, clavulanic acid is actually diffusing out and then potentiating the ceftazidime. So to produce this phantom zone. Here as well, it is completely cefotaxime resistant, but you see, because of clavulanic acid here, it is producing in phantom zone. So these are again ESBL. This one is most likely, if you have to be pushed to ask, then it might be an cefotax like CTX time type of ESBL, but without comparison, difficult to say. There might be complex pictures like that, which is in the first glance might appear very confusing, but just pay attention to that. The same principle, apply the same principle. There is a clavulanic acid, there is ceftazidime, there is cefepime, there is cefotaxime, there is cepodoxime, and there is piptas. Now what's happening here? Cefepime zone would have finished here, but there is an extension of the zone. Cefotaxime, there was nothing, but there is an extension of the zone. Capodoxime, there is nothing resistant, but there is an extension of the zone here. Ceftazidime, there is a zone which should have finished here, but there is an extension of the zone. Astronome, there is nothing, but that is probably too far away. That's why you're not seeing. Piptas, there is a zone, so obviously it's not that much affected. So here we found that there is some zone against ceftazidime, there is no zones against cefotaxime. So this is most likely a ESBL and most likely a third generation, sorry, CTX type, CTXM type of ESBL. And because clavulanic acid is doing something and it's preferentially hydrolyzing cefotaxime. Cefepime is zone size. So you might ask that how come there is a zone size around cefepime? Now, now, what I'm telling you is all principles. In real life, the situation is much more complicated because not all ESBLs or AmpC, all these enzymes are expressed in the same way. Sometimes AmpC ESBL might be hyperproduced, might be produced in large amount, and that might have a different pattern. Sometimes they might be produced in a low amount, and you might see some differences. But in the exam situation, to give you hint, the examiners have to give you some sort of definite criteria so that you can interpret it. But when you are testing in real life, you have to go by the basic principle, the base principle, but there might be variation and you might need to take that variation into account. Here again, see, there is no zone around CTXM, but because of clavulanic acid, there is a big zone. So is around cefepime and so is around astronome. So again, this is an ESBL. This is how you treat ESBL. This has been taken from IDSA guideline, and I have just changed it to kind of make sure that it has all the antibiotic that we use in UK. You will be able to check it in. You have to find it in Moodle. Now let's go to AmpC. So this is our first slide where we started. So we'll go to AmpC now. You remember that AmpC inhibitors are boronic acid and cloxacillin, and they are strong inducers. So here the inducer come into action. So AmpC can be of two types. One is constitutive and one is inducible. So to give you an example here, Mark Ruffalo is our Professor Banner, who is normally a Professor Banner, but when he becomes angry or something angers him, he becomes Hulk. So this whatever angers him or the anger is the inducer of him becoming Hulk. Similar way, There is some bacteria which will normally not produce AmpC, but if you give them these antibiotics, they will start produce AmpC. So this is called inducible AmpC. On the other hand, there are certain bacteria, like here, smart Hulk, he's always Hulk. He doesn't need to be angry to become Hulk. So these are constitutive. So this produces AmpC from the very beginning, and they are always producing AmpC. You do not need any inducer for them. They might not be producing large amount AmpC. They might be producing very small amount AmpC, but they are nevertheless producing AmpC. So these are some examples. So inducible AmpCs are like those Enterobacter, Clostridium prudenii, Morganella morgani, Providentia, Hafnia, Serratia. So you might have heard of different kind of acronyms like HEC-ES. So those are kind of made for this inducible AmpC. But there are constitutive AmpC in E. coli and Shigella. Now you might say that, oh, why we don't see E. coli that often? Yes, they often produce in small amount and not might be very obvious, and not all E. coli will produce AmpC, but it has been known that constitutive AmpC can exist in E. coli and Shigella. Now these are in their chromosomes. These AmpCs are in their chromosome, in this bacterial chromosome, but AmpC can also exist on plasmids, and sometimes this plasmid related AmpC can be acquired by bacteria, and we have found these acquired plasmids are usually seen in these bacteria like E. coli, Klebsiella, Salmonella enterica, and Proteus mirabilis, and also Morganella morganii. And this plasmid mediated AmpC, if bacteria acquire it, usually they produce the AmpC. It is not an inducible. So if the bacteria, if a Klebsiella pneumoniae get a AmpC via a plasmid, then it will express it. You do not need to induce it by giving coamoxiclav or anything like that. Only one of them is an exception, that is DHA type of AmpC in Morganella morganii, which need to be induced to be produced. So this one is an exception. So there are different type of MC which people encounter in clinical practice. You don't need to remember the names, but if you want to remember this one, CMY2 like AMCs are the commonest type of MC that we see in the clinical practice. So the commonest type of ESBL or CTXM, and commonest type of MC is CMY2 like MC. How do we screen for AmpC? So we screen for AmpC using cefotaxime resistant or ceftazidime resistant, so a third generation cephalosporin with cefoxitin resistant. If cefoxitin, this is something that actually kind of tell us that this is AmpC, because you wouldn't see it in ESBL. So cefoxitin resistant and third generation cephalosporin resistant together kind of considered a screening for AmpC. If you find that screening positive, then you go with synergy with cloxacillin. This is as per UCAST. They do not mention this second bit, which is induction by cefoxitin, but this is something that can be done to check for constitutive AmpC, inducible AmpC, and I will explain it better. So the advantage of the point I want to make before we move on is constitutive AmpC is always expressed. So say a patient coming with an AmpC producing E. coli. If you test it in clinic in your and you have a blood culture, and if you test it test the sensitivity on that E. coli, you'll find it is AmpC producer, and you can actually tailor your treatment based on that, no problem. So that you will avoid coamoxiclav and piptas and give the appropriate antibiotic. So this is easy to detect because it is expressed. But what happens with Enterobacter and Citrobacter fruendii is that they might not be producing AmpC when you first find them in the blood culture. So a patient coming with, say, biliary sepsis, and you find in the blood culture there is an Enterobacter cloacae. You do the sensitivity test and you find that it is not an AmpC producer. There is no marker to say that it's AmpC producer. It is cefoxitin sensitive, it is third generation cephalosporin sensitive. But then you came to know that the doctors has given coamoxiclav, and the patient is kind of not responding or deteriorating. You ask for a repeat blood culture and you find that this Enterobacter cloacae is now an AmpC producer. So that is the problem with this group of bacteria, that in the initial testing you might not find it, and if it's been treated with coamoxiclav, then the trouble starts. That's why in UCAST um, intrinsic resistant table, you will find that they say Enterobacter cloacae is intrinsically resistant to coamoxiclav. They will ask you not to release coamoxiclav for this group of bacteria, because they do not want to want you to give that choice to the clinicians. So that's the problem with inducible AmpC. Now, here, when you test with cefotaxime and ceftazidime and cefoxitin resistant, you will find those bacteria which is already producing AmpC. You won't find them if they are not. So this is something that is for constitutive AmpC, something like bacteria which is already producing AmpC, or for inducible AmpC, for those bacteria which when they start producing AmpC. You can use in the laboratory, you can use cefoxitin to induce them, but we'll come to that later. So if you get screening positive, you test with a synergy with cloxacillin. The same way we have tested with clavulanic acid, you instead of clavulanic acid, you use cloxacillin here. So a few more points here. Cefoxitin can give you a false positive impression that it is an AmpC, because cefoxitin resistance can be also due to porin loss. Cefoxitin, as you know, is normally inhibited by AmpC, but only one that is not party to that, that is ACC type of AmpC. So cefoxitin will be um, so all AmpC will be resistant to cefoxitin except this one, ACC. Boronic acid is another inhibitor of AmpC, but we normally do not use it because it can inhibit class A carbapenemase and K2, K1 producers as well. So you might get confused with that. So that's why we mainly use cloxacillin. So there are points to remember. Is there any way of differentiating chromosomal and plasmid mediated AmpC? Genetic testing only. Normally we do not do it. Okay, so here are some plates that we can interpret to give you an idea that how we do it. So here ZA is cepodoxime, ZB is cepodoxime plus clavulanic acid, ZC is cepodoxime plus cloxacillin, ZD is cepodoxime plus cloxacillin plus clavulanic acid. So both ESBL and AmpC inhibitors are there. Only AmpC inhibitors there, only ESBL inhibitors there, no inhibitor there. So what is happening here? This one, cepodoxime resistant, ESBL inhibitors are there and it is producing a big zone. So it's possibly ESBL. AmpC inhibitors is not producing anything. Here there is a big zone. It is because of the ESBL inhibitors, because the cloxacillin inhibitor is not having any effect. So this one is an ESBL producer. Here, cepodoxime resistant, there is no effect on ESBL inhibitors. There is a big zone when we use the AmpC inhibitors, and there is a big zone here. So this is because of AmpC, and this zone size is only because of cloxacillin. Clavulanic acid is not having any effect here. Difficult one is this one. So here, cepodoxime no zone size. Here there is no zone size. Okay, so it could, I do not know what it is. It could be it cannot be ESBL. It could be AmpC, because if there is ESBL, then you would have seen a zone size, but no zone size, so it could be an AmpC. Oh, hold on here. Now there is no zone size even around this one, so it cannot be AmpC, but it could be ESBL. Here, see, zone size around both of them. So here, clavulanic acid is actually, so that means you need both clavulanic acid and cloxacillin to produce this zone. So what's happening here? Here, clavulanic acid was trying to break free, but because this organism is also AmpC producer, it didn't allow it. Here, cloxacillin was trying to break free, but because it's also an ESBL producer, it didn't allow it. Here, both ESBL and AmpC are inhibited, and you see a zone size. This one is AmpC and ESBL both positive. So this one doesn't matter, everything is negative. So this is AmpC and ESBL negative. So you just need to kind of logically explain that what you see, and then you can get the answer. So this is what I was saying about cefoxitin, that how you can test for inducible AmpC. So here, so for example, you have found Enterobacter hermachii, which is can be an inducible AmpC producer. So you put a ceftazidime disc, you put a cefotaxime disc, you put a clavulanic acid, and you put a cefoxitin here. So same thing here. Now what you see is that there is a blunting of zone here. What is happening is cefoxitin is inducing AmpC producer in this part of the bacteria. So cefoxitin is inducing this part of the bacteria to produce AmpC. So as a result, this bacteria is able to break down cefotaxime and it is producing a blunting of the zone. But there is no cefoxitin on this side, so these bacteria are not producing AmpC and are inhibited by cefotaxime, ERSImer. This is not ESBL, because if it's one ESBL, then you would have found that this zone size wouldn't have finished here. It would have been like this. Okay, sorry. The same thing here. Cefotaxime, cefoxitin is actually inducing it here, and that's why you are seeing a zone size D formation there, like the D test you see for macrolide and clindamycin. It's similar. So it's an proof that there is an inducible AmpC in this bacteria. It's a similar test where you put the test this disc with the with your test bacteria, and if it's an inducible AmpC producer, then cefoxitin will induce AmpC production here, and it will break down the cefoxitin itself here, and that's why the bacteria which is on the culture plate will encroach here. So this is something like a normal E. coli. It is not an ESBL producer or anything, or AmpC producer. It is just a normal E. coli. Test ATCC strain E. coli. Now you have learned it. Now here you put an cefoxitin disc and you put your test bacteria here. Cefoxitin disc, your uh, what is called B. So this must be a negative control. Yeah, these are probably negative control. Now here, what you see is this cefoxitin is inducing the test bacteria, like say if it's an Enterobacter cloacae, and you have put a cefoxitin. So it is inducing the AmpC production here. And because it is producing AmpC, it is breaking down whatever cefoxitin is produced here, and E. coli is able to encroach in here. So this is a um, test for inducible AmpC. Whenever you see that there is an effect because of cefoxitin, it is most likely an inducible AmpC. This slide is based on IDSA guideline. So IDSA came up with divided the bacteria which is inducible AmpC producer into three groups. First group, there is a high likelihood that they will produce AmpC if you induce them. So likelihood can go up to 40%. 40% chance of treatment failure because of AmpC production. And these are Enterobacter cloacae, Citrobacter fruendii, Klebsiella aerogenes, etc. Low risk of AmpC production, the risk of treatment failure is less than 5%, and these are like Serratia, Morganella, and Providentia. And even less is organism like Hafnia alvi, Citrobacter youngii, and Yersinia enterocolitica. This chart is important. Question has been asked on this one. This is another chart which is important. Again, question has been asked on this one. So let me explain. This is taken from IDSA guideline again. So AmpC producers, there is some antibiotic which are weak inducers, some are strong inducer, some are substrate, some are non-substrate. So meaning of that? Weak inducers means that if you give this antibiotic to a AmpC producer, inducible AmpC producer, for example, say Citrobacter fruendii. If you treat Citrobacter fruendii with piperacillin tazobactam, it might produce AmpC. It is a weak inducer of AmpC. Similarly, ceftriaxone, ceftazidime, it is a weak inducer. But if it produces AmpC, then it is going to break down these antibiotics substrate. So treatment will fail. So for example, I've got a patient with blood culture, which is Citrobacter fruendii, and I've given them piptaz. There is a small chance that piptaz might induce AmpC production in Citrobacter fruendii, and if it does, then treatment will fail because piptaz is a substrate of AmpC. It will break it down. On the other hand, if I give coamoxiclav, it's a strong inducer and there's a high chance that it will induce the AmpC production. And if it does, treatment will fail. So giving a Citrobacter fruendii bacteremia coamoxiclav is much, much higher risk than piptaz because it's a strong inducer. Both of them are substrates. So if you give that, if they produce AmpC, it is going to break it down. So cefoxitin C is a strong inducer. That's why we have used cefoxitin in this test to induce AmpC production because it's a strong inducer. You can actually put here coamoxiclav as well. It will probably be the similar test. So there, these are strong inducer and substrate. These are weak inducer and substrate. On the other hand, if you treat that patient with imipenem, it is most likely going to induce AmpC production, but it will not, treatment will not fail because it is not a substrate. Imipenem can still kill the Citrobacter fruendii. Cefepime, it is a weak inducer, and even if its AmpC production starts, it will not be affected because it is not a substrate. Right? There are these antibiotics which are non-beta lactam, are non-inducer and not substrate. This is our last slide. This is the treatment of AmpC. Now, I wouldn't go into the detail of the treatment. This is based on the likelihood of AmpC production, um, and the treatment is given. Here, we do not usually have cefepime in UK commonly. You can probably get it, but with much difficulty. We tend to use carbapenem in that case or some sort of non-beta lactam. So you can find this one in Moodle. This is made based on IDSA guideline and you can read it from there. Thank you.